Thank you. So good evening, everyone. My name's Dr. Neeraj Kalra. I'm one of the clinical instructors here at Stanford in neuro-oncology and radiosurgery. And it's my great privilege to be able to talk to you this evening on meningiomas, a topic that I've got great interest in. Just some general housekeeping before I begin. So you can see me, I can't see you at the moment. I know we've got some question and answer session planned at the end of the talk. Happy to answer anything that I can. I won't obviously name any names, and I do have to caveat this by saying that I don't have access to anyone's scans. I can't give you formal medical advice. So without much further ado, let's begin. So a little bit about me. I'm, as you may be able to tell by the accent, UK trained. I did my neurosurgery residency in the United Kingdom, and that's where I'm board certified. I did a Royal College of Surgeons approved neuro-oncology fellowship, so I specialize in brain tumors of all variety. And I'm here working, I have the great privilege of working with Dr. Stephen Chang and Dr. David Park on the neuro-oncology and radiosurgery program. I've got no conflicts of interest to declare. So as a general overview of what I'd like to cover today, so we've got a few objectives. So the first thing is sort of recognizing imaging patterns and red flags for high-risk tumors, knowing about the WHO grade, key molecular markers that change our management plans and the implications they have for you as patients, practical pathways, observation, surgery, radiation, sort of the way we as clinicians look at things, and to help you make an informed decision, sort of things that can go wrong or things that happen post-operatively, and sort of evidence-based surveillance intervals. When should we be doing scans? How frequently, etc. So as a general flow, we'll spend about 5 minutes on the background, 10 minutes on imaging and grading, 10 minutes on treatment and decision-making, sort of follow-up. We'll talk about for 5 minutes, and I'll leave sort of 30 minutes towards the end of this for questions. So start with the background. What is a meningioma? How common is it? What are the risk factors? And where does it occur? So what is a meningioma? And the way I like to think of it, the brain and the skull, is that the brain sits in our skull, but it's not just sitting there in the skull. It's surrounded by a sac. And that sac keeps the brain within it. It keeps the cerebrospinal fluid within it. It keeps the blood vessels within it. And it keeps it fairly stationary. It keeps it static. It prevents or it absorbs a lot of shock, and it provides nutrients through the fluid. That sac is called the meninges, and it's formed of, as you can see on the left here, the dura mater, the arachnoid mater, and the pia mater are sort of the three layers within the linings of the brain. And traditionally speaking, meningiomas are said to arise from the dura mater, so the lining of the brain. So they're not brain tumors directly. They don't come from the cells of the brain. They come from the lining of the brain. And what we tend to find is that they cause their effects by pressing on the area of brain that they're nearest to. And that's called mass effect. And that's why a lot of times patients will find that their meningiomas are picked up because of something that they've noticed, be that weakness, change in smell, anything else. But quite often we pick up meningiomas incidentally, and that's because they're either very small and the pressure they're causing on the brain is not causing any signs or symptoms, or the area that they're pressing on, even though it's quite large, the tumor is not eloquent enough, or the changes they're causing are very subtle. So meningioma is the most common brain tumor in adults, and it makes up about 43% of brain tumors, and it's the most common non-malignant brain tumor. And I'll touch back on that phrase later on in the talk. But the vast majority of these tumors, we'd say, are grade 1 or benign. They're more common in women, and that's because some of them have hormone receptors to estrogen and progesterone, with natural hormonal changes that occur during a woman's life, as well as hormonotherapy they may be taking in form of the oral contraceptive or HRT. There have been some suggestions that those can increase the incidence and the risk of developing them. Generally speaking, we find these tumors in people in their 60s to 70s. That's the highest incidence. And the incidence is going up because we're doing more imaging. So we're doing more imaging now than we did 10 years ago, 20 years ago, 30 years ago. And as such, we're picking up more incidental tumors. So there's about 8 to 10,000 cases per 100,000 in terms of incidence. But if you went out now into Stanford and you scanned 1,000 people, you'd find one brain tumor, you'd find one meningioma there. And there are some risk factors associated with meningioma. So the biggest one is a exposure to ionizing radiation. So if you've had a lot of exposure through work or environmental factors or previous radiotherapy for another type of tumor, you can expose you've had that exposure, you increases your risk. NF2 and other rare syndromes, those are associated, and the hormonal associations, which I've touched on, are very complex, and I don't think they're truly that well understood. So common locations produce predictable syndromes. So as I mentioned at the start of this, a lot of the things that we pick up from these tumors are based around the pressure that they're causing on the brain and the dysfunction that occurs as a result of that. And we can sort of predict where that dysfunction occurs by the signs and symptoms that patients exhibit. So in this bottom right corner, we've sort of given the percentages of the location frequency. So convexity means on the outer sort of surface of the brain, the convex surface, so towards here, and that's the vast majority of tumors. That's 35% or so. Parasagittal. So between the two hemispheres of the brain, you have the sagittal sinus, which is a major blood vessel, and then you also have a meningeal layer here, which divides the two hemispheres. And so quite often we can see tumors very close to that, coming off parasagittally or coming off the meningeal lining between the two hemispheres. And they're the second most common. That makes up about 25%. Sphenoid wing. So the sphenoid wing is towards the base of the skull, and it is one of the grooves we have in the brain. And there, the dura quite often produces our meningiomas, and they're 20%. The olfactory groove towards the front of the base of the skull is where your olfactory nerves run. They control your sense of smell, and quite often we can see them meningiomas there. And then posterior fossa towards the back of the head, towards your cerebellum. And depending on where they are, is what determines the symptoms we'll have. And I've put that up here. So if we have convexity meningiomas, quite often, but not always, they'll present with seizures or headaches or swelling. Weakness, potentially, you can have arm or leg weakness. And the same with parasagittal. Leg weakness is quite common. Occasionally, very rarely, but it does happen. We see patients who've had spinal surgery because they've had leg weakness, seen no improvement. And the leg weakness has progressed. And on imaging the head, we find there's a meningioma that has been causing compression of the brain. Olfactory groove, so anosmia, so loss of smell. Personality changes if there's big frontal lobe compression. The tuberculum sellae back here is very close to where your optic nerves cross, your optic chiasm, and you can get visual loss associated with that. Your cerebropontine angle, so back in the posterior fossa, we can have problems with fluid buildup in the brain, problems with walking, and specific cranial nerve deficits, so facial pain, facial weakness, for example. What do we do in terms of imaging? What's important, what's typical, and what are sort of the red flags that we look out for? So these are some pictures I've just pulled off the internet. These are classical meningiomas, and you can sort of see them here. So this picture is an MRI scan. All of these are MRI scans except for this, which is a diagram. In this instance, we're looking at the person's sideways zone. So that's their nose, back of the head, top of the head. And I always like to tell people that the brain is a very symmetrical organ. If you see something that's there on one side, that's not there on the other side, tends to lead you to believe that may be abnormal. And this is an MRI scan where someone's had some contrast, and we can see this big white area here. That is the meningioma, and it's fairly sizable. Here is a slightly different sequence. So we're looking at the patient lying down, front of the head here, back of the head, left side, right side. And we can see this big mass, the frontal lobe here, and the white area around it is the cerebrospinal fluid, and that is sometimes referred to as a CSF cleft. And I've sort of mentioned that here. That is one of the classical things we see with meningiomas. So they're extraaxial. That means they're not coming from the brain themselves. They're associated with a CSF cleft quite often. In this tumor here, we can see a small cleft just over there. They enhance uniformly, usually. I know this doesn't look like it, but a lot of the black dots you're seeing in there are blood vessels. This is fairly uniform. Again, fairly uniform down here, and we can see the blood vessels supplying the tumor there. There's something called a dural tail. So although all of this is tumor, quite clearly, we can see that there's an area along here which extends, and that is also part of the tumor called the dural tail, which we try and excise where possible because we know that area that can be a possible area for recurrence. Along with this, we'll get some bony changes associated with the tumor, so you get a bone growth, not bone destruction, generally speaking. And that's another telltale sign of what we're looking at is a meningioma. And around these tumors, quite often we find patients present because all of a sudden something has gotten worse. And the reason for that may not necessarily be tumor growth, but maybe swelling of the brain around the tumor, something called edema. And the scan in the top right, we can see that there's some white areas in the brain itself, and that is probably swelling associated with the tumor. And we try and bring that down with steroids, usually as a temporizing measure until we move towards further definitive treatment. Now, we always should keep an open mind when it comes to these sorts of tumors. When you see something that looks classical, great. More often than not, it is what you think it is. However, sometimes we see things that are atypical, and we need to keep an open mind to not just rush to the common diagnosis. So if we see things that such as bony destruction, edema that is atypical, swelling that is atypical and not in keeping with the size of the tumor, or irregular margins around the tumor, we can see for all of these are pretty smooth. We need to keep that differential open and escalate out to a tumor board, a multidisciplinary review. So, I mentioned hyperostosis. So this is a CT scan of the head. That is the right eye, that is the left eye. And we can see here there's a marked difference, an increase in the size of the bone here relative to that size. And that's reactive thickening adjacent to the tumor. And in this instance, it will drive symptoms. It will cause optic and orbital compression, and that may lead to a loss of vision. And it may represent a tumor invasion into the bone itself. And as such, when we come to treating, be that surgical or with stereotactic radiosurgery, we need to keep that in mind as part of the area for treatment. And it is fairly common when we see these types of tumors. Conversely, looking at the two pictures below, we see this white area here has been eroded. The front of the skull has been eroded by the tumor. And that is atypical for a meningioma. And so we want to think about other things, aggressive tumors, meningiomas, solitary fibrous tumors. Look at the MRI as well. And again, it's something that we need to have low thresholds for a tumor board discussion and discussions with our neuro-oncology colleagues very early on to make sure that we've got the right treatment plan in place for everyone, to make sure that we are expediting things if adjuvant therapy is required. So the red flags, as we've talked about, irregular lobulated margins, ununiform enhancement, so looking patchy or signs of necrosis, the tumor dying because it's growing so quickly, the blood supply can't keep up with it. The edema or swelling around the tumor being disproportionate for a tumor of that size. Signs of brain invasion, so parenchymal invasion, that means invasion of the tumor into the brain. Now, that doesn't necessarily mean it's not a meningioma, but it may mean that it's a higher grade of meningioma, and we'll touch on this later on. Bone destruction versus hyperostosis, so is the bone breaking down as opposed to getting bigger with tumor. Multiple lesions. You can have syndromes where you get multiple meningiomas. However, we need to keep an open mind when you've got multiple dural lesions. And just on the right, there's a few things that I've mentioned that this could be as an alternative. So solitary fibrous tumor, metastases from a cancer elsewhere in the body, lymphoma, inflammatory. So this brings us on quite nicely to treatment. What do we do? And there's sort of three options the way I see it. Observation is always a form of treatment, and it's very reasonable for a lot of people. Surgery has quite often been the mainstay of treatment, and radiosurgery and fractionated radiotherapy. So this is a sort of decision matrix I've put together. And there's sort of, we go from top left to bottom right in terms of severity, I'd say. If you've got a tumor, a meningioma that's asymptomatic and stable, you have all three options available to you. Observation is very reasonable. Say, well, I've not got any symptoms. The tumor is stable. Let's keep an eye on it. We know that these tumors don't necessarily grow uniformly throughout life. And especially on your first scan, we don't know how long this tumor's been there. So you don't have to, in these instances, you don't have to necessarily rush in to do something. And it is not unreasonable to say, let's just wait and see how this goes. Moving on to sort of the yellow areas here, asymptomatic with growth, mild symptoms plus stable. So we're getting into the territory now of actually this tumor's changing a little bit. It may be on a growth, it may be having, a teenage growth spurt, or it's causing you problems, in which case, what do we do? You can say, well, we'll consider observation here. That I feel may be pushing the can down the road slightly because you're symptomatic, or we're seeing that tumors beginning to grow. But if it's very slow growth, very small growth, again, not unreasonable. Surgery becomes an option here. If you are symptomatic, the quickest way to remove those symptoms is to remove the pressure of the mass effect that tumor is causing on the brain. So we go in, we do the operation, the brain then is able to re-expand. The other option is stereotactic radiosurgery, or SRS. And here at Stanford, we offer CyberKnife. It was invented here. I think we do some of the largest numbers globally. And that's very good for small to moderate, well-circumcised tumors without huge amounts of eloquent structures near them that can tolerate radiation. And the aim of stereotactic radiosurgery is to stop growth. So that means it's very good if you've got small tumors or tumors that are asymptomatic, because it means that we're trying to avoid having an operation and the risks associated. But at the same time, we know we're killing that tumor and stopping any growth. If you've got symptoms that because of the pressure the tumor is causing, stereotactic radiosurgery takes some time to work, and it may not necessarily decrease the size of the tumor, so your symptoms may not get better. And so that takes us further along this sort of treatment pathway where you've got symptomatic growth, asymptomatic, but you're near critical anatomy, and you've got seizure and edema, and the tumor is accessible. In this instance, we're being pushed towards intervention here more so. And I think where we are the only group here that I'd say we should really have stereotactic radiosurgery are here, the patients who are asymptomatic and near critical anatomy. Your surgical risk is high, asymptomatic, the tumor itself isn't causing you any problems, you're asymptomatic from it, but we can deliver stereotactic radiosurgery to prevent that becoming a problem. Then we move further along, and towards this end of things, we start talking more and more towards being a surgical bias and looking to take away as much of the tumor as possible, as safely as possible, to minimize the effects that it's having on the brain. Now here, I've also mentioned fractionated radiotherapy. That's something that we give larger tumors, those close to the optic pathway, brainstem, higher grade, and after subtotal resection potentially. But Dr. Gibbs, one of our very senior radiation oncology attendings, will be giving a talk on that sometime in the near future. Location of the tumor and the veins near the tumor dictate what's safe for us to do versus taking everything out. And we can do a lot of these therapies in conjunction. So we can offer surgery and then CyberKnife, or CyberKnife and then surgery together to make sure that we keep patients as safe as possible, as good functionally as possible, whilst taking away as much tumor as we can. The primary goal of surgery should always be to obtain a diagnosis and a grade of the tumor. And we do this to relieve the mass effect and to help with any neurological symptoms that you may be having. We should be aiming for control. So we want to stop the tumor growing where possible and safe, and aim for a gross total resection when feasible. But the key is we need to preserve normal structure. So preserve the venous sinuses, the major veins in the brain, and the cranial nerves. So the nerves that control a lot of the function in the face, in your swallow, your eyes, things of that nature. Extent matters, and the extent of resection matters because the more we can take out, the lower your risk of recurrence. So the lower the Simpson grade, the lower the recurrence risk. We've moved away from, I think, maybe 10, 20 years ago, where we would say we have to get all of it out, irrespective of what that means, to a state now where we say, well, actually, we've got all these adjuvant therapies, which are non-invasive. We can leave some tumor behind to avoid morbidity. But we need to know what the residual location is and what the planned strategy is. And actually, I think a lot of that can be done preoperatively, and you can have that discussion with us or with your surgical team and say, can you take all of this out? What's your plan if you can? What's your plan if you can't? What about adjuvant therapy? What about observation? Now, this man, I don't expect anyone to know. I could show this photo to most neurosurgeons. They wouldn't know who this is, but this is Professor Donald Simpson. He was a Australian neurosurgeon. He's famed for his paper in 1957, which showed that the degree of resection correlated with the degree of recurrence. Now, nobody recognizes him, but people we all do recognize are the Simpsons. And I think they portray actually a very good way to know how much of the tumor we've taken out. So degree of resection. So grade 1, the most we can take out is complete removal of the tumor, the dural attachment, and any abnormal bone. That doesn't necessarily mean we take all of the bone away, so you're left with a defect in your skull. It means that we sometimes drill the inner lining of the bone, so any tumor that may have invaded into that, we sort of drill away and cauterize and then put the bone back. Grade 2, or Simpson grade 2, is complete removal of the tumor, but where we can't take the dural attachment, so in the skull base, for example, we will coagulate or with diathermy or burn that area to try and kill it off so that there's no recurrence. Grade 3 is very similar to grade 2, where we've taken all of the tumor out, but we can't coagulate, we can't burn that dural attachment for a variety of reasons. Grade 4, subtotal resection, so we've had to leave some tumor behind. And again, there's a variety of reasons why that happens. And grade 5 is a simple decompression or biopsy only. And again, variety of reasons why that may happen. And there is now sort of a new feeling that we should start talking about grade 0, which is an ultra radical resection. So not only do we take the dura around the tumor, but we include a wide dural margin of 1 centimeter or 2 around that where possible to prevent risk of recurrence. So these are the recurrence rates. These are your recurrence rates with surgery alone. So if we manage to get all of the tumor, all of the dura that we see enhances, and the bone, at 10 years, we see a 9% recurrence rate. And that goes up with the less tumor we take, the higher your risk of recurrence. And it's important to note that this is radiological recurrence. These are not our numbers. These are not Stanford's numbers. These are numbers that are well published in data, and they're means of numerous literature series. And it is in many ways common sense. You say we've taken less of the tumor, the likelihood of it coming back is greater. And that's why we aim to take as much as possible. But recurrence doesn't necessarily mean symptoms. It may be that we've taken out a 4 or 5 centimeter tumor, and 10 years down the line, we see a millimeter's growth. It doesn't necessarily correlate with functional change, but radiological change. On the right-hand side, we can see actually by the aggressiveness of the tumor, the WHO grade, the recurrence rates go up. So grade 1, depending on which set of literature you read, we will say 7 to 25% over 10 years risk of recurrence with surgery alone. Grade 2, and that's with a Simpson 1 resection, depending on the series. Grade 2, 29 to 52, and grade 3 almost certainly will need adjuvant therapy and isn't necessarily always classed as benign in most centers. So post-operatively, what do you need to worry about? So common complications that occur. Declining mental status, so it can be from a bleed or a swelling. A new focal deficit, again, bleed, stroke, venous bleed, venous infarct, seizures, severe headaches or vomiting, uh, wound leak can occur. And if we're operating the skull base, you can sometimes have cranial nerve deficits, problems with speech, problems with swallow. We should always get emergent post-op imaging if any of these occur to see what's going on, to see if there's anything lateralizing, if you're experiencing features of headache or vomiting, refractory seizures, or when we think there is a potential cerebrospinal fluid leak with meningism. These risks are rare, but I think anyone who's having their head cut open needs to know about them. And they are, because they're serious, and in some instances, they can be devastating. So radiation therapy, I'm not going to spend a huge amount of time on this because I know Dr. Gibbs is going to give a talk as well, but it is important, and I think it should become more and more discussed as a form of not only adjuvant therapy, but as primary therapy. The machine you see on the left here is the CyberKnife machine. So it's quite a nice machine in that you are sat in an open room. It's not like having an MRI scan, and the robot moves around you, delivering the radiotherapy in very targeted sub-millimeter accuracy. So generally what happens is you will come in, have a CT scan, have an MRI scan, go home. We fuse these images as a team. We draw the tumor out. It gets sent to a lot of people to check everything is safe, the radiation dose is correct. And then we bring you back in for a few days later. And this is an outpatient procedure. There's no anesthesia required. There's no real downtime. I tend to tell people if you opt to have CyberKnife therapy, you'll be gone for half an hour, 40 minutes. You drive yourself in, you can drive yourself home. Before anyone knows, you've been shopping for 45 minutes. There's no stigmata of having had any therapy. And it's very good for small to moderate, well-defined tumors. And it's good to use for any residuals, any recurrence, any tumors that we suspect are sort of grade 1, grade 2 potentially. Areas we avoid it if it's close to the optic apparatus or the brainstem because we're limited by the dose of radiation we can give there. Fractionated radiotherapy is something else that we give, and that's given predominantly by the radiation oncologists, but it's more for larger tumors, for those that we can't give stereotactic radiosurgery for, grade 3, grade 2 tumors after subtotal resection. So let's go back to our recurrence rates. So when we talked about Simpson 1 for grade 1 tumors, I showed you the table on the left. If we offer CyberKnife in conjunction with that, we reduce those recurrence risks massively. And actually, Simpson grade 1 is fantastic. If we get Simpson grade 1, we're basically saying your risk of recurrence in the published literature is close to 1% at 10 years of radiological recurrence. It's not necessarily even significant. Grade 2 is 5 to 10%. Simpson grade 3, actually, by doing this, by having surgery, leaving some of that dura alone, we move you from, Simpson 3 to similar percentages to having had a Simpson grade 1 resection. And then Simpson 4, 5 still not as good as we'd hope, but there's probably something underlying that as to a reason we've not been able to do a greater resection. I think this is a very key thing. The recurrence rates of 10% are 10 years with CyberKnife alone. That is the data we can show for the tumors that we operate on, that we offer CyberKnife to. So 10% recurrence rate over 10 years is equivocal to a Simpson 1 recurrence. So at 10 years, your risk of the tumor growing, if you have CyberKnife or surgeries, is pretty much the same. What happens after local therapy? And again, I think this is something that's better managed by the radiation oncologists. They're the people who do this, but local control is still the most important thing. If the tumor recurs and we need to do something, the best thing we can do where feasible is re-resection. Then radiation as well is a great option to have, particularly if it's a very small recurrence. So offering something like CyberKnife to the recurrence area minimizes the risk to you because you're not undergoing a second operation, third operation. We can do repeat CyberKnife therapy for these lesions if they come back. If there is growth, we can always redose. And I think we are progressing in what we do. So we're using new forms of scans now, the dotatate PET scan, to look at the areas that are affected. And what we're finding is that quite often in patients that we thought we'd got Simpson 1 resections for, on the dotatate PET scan, which shows area of high cellularity, there's areas that we've missed, and those are the areas that correlate with recurrence. So in using those scans, we're able to better target and bring those recurrence rates down. But then there are the systemic options managed by the oncologists. As far as I know, there's not an established standard systemic therapy. But again, that's something that I would suggest you speak to your oncologist about. So risk stratification. Back in 2021, the WHO grading around these tumors shifted. We used to purely diagnose and grade these tumors around what the pathologist saw under the microscope. We know that tumors who we did this for didn't behave the way we'd expect them to, and we found a whole raft of molecular markers now which can override that histology. So it's not just about what we see under the microscope, it's about what we see with molecular testing. And one of the things that really changed was brain invasion. And that on its own is a criteria that suggests that a tumor is more aggressive, even if it doesn't have a high rate of division or any of the cellular markers. The fact that it's not got a clean plane between the tumor and the brain suggests actually we need to be treating these more aggressively. So as I said, the vast majority of the tumors that we see are grade 1, benign. They have low cell division, low turnover, no brain invasion. And actually, the recurrence risk is pretty much down to the extent of resection in the location. Grade 2, atypical, about 14-15%. And they've got a slightly higher rate of cell division, or they've got brain invasion, or the specific cells we see within that tumor that makes us aware that they're at higher risk of recurrence. And they're the tumors that need closer surveillance and further adjuvant therapy, depending on individual discussion and what we see on surveillance. Grade 3, so these are malignant. They've got very high cell turnover, high mitotic activity. There's certain molecular alterations within there that we say actually these molecular profiles are high risk. There's a high recurrence risk. I know in the initial slide I showed it somewhere between 50 to 94%. And they need multimodality therapy, so neurosurgery, neuro-oncology, radiation oncology, and they need very close surveillance. Molecular markers. So these are the things we see in reports, and these are sort of our things to recognize as physicians. NF2 alterations, TRAF, KLF, AKT, SMO. These are helpful, but they don't necessarily change your risk. The high risk ones that we need to keep an eye on are TERT promoters, and that associated with the worst prognosis, CDK2N, A2/B, homozygous deletion. That on its own, even without the mitotic changes or brain invasion, puts you in grade 3 because of the risk of recurrence. And then for that, if either is present, we increase surveillance and we discuss early adjuvant options. So how often should we be doing scans? Is there a set pathway? Everyone is unique. Everyone is individual. Everyone has individual circumstances. But there are guidelines out there, and these are just some that I've pulled from the European Association of Neuro-Oncology. And it varies, again, depending on WHO guidelines. But again, I will say your personal scan frequency may not match this. And that's, this is all case dependent. But for WHO grade 1, what we tend to say is we'll do a scan, a baseline scan 3 months post-operatively, and depending on what that shows, you can go to a year, 6 monthly or yearly for 5 years, and if everything's stable, 2 yearly. Grade 2, WHO grade 2, so we do an MRI scan post-operatively as a baseline MR, or at 3 months once everything is settled following the operation, and then 6 monthly for 5 years, and assuming again everything's stable, annually. For grade 3, again, it's very, very case dependent, and it depends on the clinical course, but the EANO recommend every 3 to 6 months initially. I think I'm going to close with this and say, just because you have a meningioma, because it's pink, picked up, it doesn't mean you have to have surgery. And it also doesn't mean you have to have stereotactic radiosurgery. Observation is very reasonable. If you're asymptomatic, if you've got minimal symptoms and a small tumor. If you're in the elderly cohort of patients who say, actually, my 10-year recurrence rate, my 10-year risk of this is pretty slow, I don't really want it. Again, that's a very reasonable thing to say. Small tumor, minimal edema, no critical structures nearby. Patients who've got a lot of comorbidities or are at high surgical risk, again, observation in the first instance may not be unreasonable. And something that we've seen is stable. If you had a car accident 10 years ago and you've had a scan, and then all of a sudden you've been unfortunate, had another car accident, and you've had another scan, and we see that tumor wasn't followed up 10 years ago, and it's not changed over 10 years. We don't need to rush in to do anything. There are certain things that are associated with growth. So younger age, we know that you're younger, got a long life to live, we hope. Your risk of the tumor progressing is higher because you have longer to live. Larger size at diagnosis, there's just more cells there. There's more cells in that tumor that are at risk of dividing. Lack of calcification. So the tumor is very bright on one specific MRI sequence, a T2 sequence, or it's not filled with calcium. We know that these tumors are at higher risk of growing. Or if we can see that it's growing, if you've had a scan over a period of time, you've had a few scans and we can see slow progression, then actually that is growth by definition. I'm going to stop sharing there and open the floor to any questions. So I'm just going to start with some questions I've got. So do radiation-induced meningiomas occur more frequently in certain locations? I don't think so. I think the distribution of them is equivocal to what the distribution was in one of the early slides I showed about where they are. And it depends on the radiation given. So if you were given radiation to a very particular part of your brain, that area has been exposed to more of it, then yes, that area would be at higher risk. But assuming it was uniform radiation from background or whatever, then your meningioma risk is increased, but your distribution would be in keeping with what we'd seen.
Oh, I wanted to mention that for those who are new to the webinar, if you have any questions, please feel free to enter your questions in the Q&A box. It's right down below.
Yeah. So I think it's very easy for us to sit here. There's a question about why people are not aware of this. I think it's very easy for me to sit here as a specialist neurosurgeon with an interest in brain tumors to say, you've got that symptom, you should be, that should ring alarm bells. But at the same time, you could ask me something about another aspect of medicine that is not my day-to-day work that a specialist in that area would know. And it might well be that I won't know the answer to that. Unfortunately, not everyone has all the answers for all the things, I'm afraid. So someone's presented with a tumor. It's on the falx, left more than right. Easier, less complicated. So you'd initially thought about doing stereotactic radiotherapy, less complications, but now that I know more, I realize they're both at risk. Unfortunately, I can't give you a definitive answer as to what to do. I think the best thing, if you're uncertain, is to go back and speak to your team. We're always happy to, Dr. Chang and I are always happy to see patients and have another discussion with them. It doesn't have to be in person. We can do it over video and say, these are what we think the risks are. You can go back to your primary team and say, look, I've had some second thoughts. Can you tell me in your hands, what are the risks? And that is that I think the more information you have, the more informed you are to make a decision. I think unless it's very barned or it's wrong for us to tell you what to do, it's my job to present you with the options and tell you what the risks are. Someone's asked if your MRI suggests meningioma, Does your diagnosis, even after the pathology, show something different? Is there a reason to keep the diagnosis as meningioma? No, you should. The diagnosis should move to whatever the pathological diagnosis, the pathology shows. That is the diagnosis. Is the risk of recurrence after treatment greater in certain locations of the brain? I do some meningiomas have locations tend to recur more than others? Very interesting question. So the Simpson grade, the long held belief is that it is about the degree of resection that you take. So if you can take more of the tumor, the less likely your risk of recurrence is. Assuming that the grade of tumor is the same, certain anatomical locations mean we are less able to take out as much as we would in another location, which means that in those locations, because there is simply more tumor left behind, the risk is higher. If I hope that makes, I hope that answers your question. Inherently, the same meningioma is not at higher risk purely because it is a meningioma. It is at higher risk because in a different anatomical location, because we are unable to extract as much of it as we could in another area. Someone has mentioned that they have a sphenoid ring meningioma with a dural tail extending into the cavernous sinus, orbital fissures. I'm afraid I can't give you particular advice on that one without seeing your scans and having a face-to-face discussion. Catherine, sorry. What size of tumor is considered large? So I think that is very variable. Size is not the only thing that matters. So size as well as location and compression. There are tumors that are 1 centimeter that will push on your brainstem that can be debilitating and life-threatening versus tumors that are 5, 6 centimeters and you won't know about them. We tend to stay when it comes to CyberKnife here. Anything over 3 centimeters, we generally won't treat with CyberKnife. So if you want to talk about a cutoff for treatment, that would be it. That is what we would say. So someone's asked, frequently patients don't want to wait and see if tumor grows. They want the tumor out of their brain. How do you handle that discussion? Yeah, I think it is a interesting discussion to have, and I think it's very individual based. So if someone says, look, I want this gone, I want it out, I think you want to explore why, particularly if there's no radiological features to suggest it's aggressive or it's asymptomatic, because surgery doesn't come without risk. And I know this may be unusual to hear a surgeon say this, but I think you can teach anyone to operate, but where the training really comes in is to know when to operate. And you want to know why someone wants that tumor out. And would offering something less invasive like stereotactic radiosurgery CyberKnife be helpful in this situation? And actually, that is often what we do. Patients who say to us, I've got a very small tumor, but it bothers me, I'm not happy with it, do something. And we'll say, actually, well, we can tell you with great certainty that if we give you CyberKnife to this tumor, as I've shown in the data in these slides, it's as good as having a Simpson grade 1 resection. So you can have the benefits of surgery without truly having surgery. And I think a lot of patients find that an acceptable solution to the problem. And you still get regular surveillance. It's not to say surgery's taken off the cards, but we've, in a way, tried to treat this tumor without exposing you to the risks of surgery and conferring some benefit. Should a meningioma patient post-surgery be worried about radiation from airplane travel and civil? Generally, no. We tend to tell patients with meningiomas, without meningiomas, get on a plane. We have patients who come from further parts of California or from out of state who get on a plane a few days later. So no, I wouldn't say you need to worry about airplane travel or background radiation. There's a question about anti-pregnancy drugs may cause tumors in women. So there is a hormonal component to this. So there are tumors that have got estrogen receptors and progesterone receptors on them, and hormone replacement therapy, contraceptive medication, natural hormonal changes women go through in their lifetimes can cause these tumors to grow. It is impossible for us to predict who that's going to happen in, and the evidence for it is growing, that these happen. We know there's receptors, and yes, some of the oral contraceptive pills or hormone replacement therapy has been linked to an increased incidence of these tumors. Are there any other treatments that are less invasive for people with large numbers of tumors, 15 to 20? I think that would need a discussion with your neurosurgeon and your radiation oncology team about what they could do for it. May be that some of them are surgically treated and some are treated with stereotactic or another form of radiotherapy. I know for other types of tumors we can treat with CyberKnife, so 10, 15 brain metastases we have done, and we can treat multiple meningiomas at the same time. Someone has asked if CyberKnife is not indicated for a 3.5 centimeter tumor in the skull base. So it very much depends. So we would look at each scan individually, but our general cutoff here is 3 centimeters. So if it's too big for that, we would generally say, no, we wouldn't do that. And we'd say, offer you an alternative. And I think it's all about offering combination therapy now. Yes, surgery may be risky in that area if you're trying to take a bit of the tumor out. But if you say, actually, we're going in with the intention of taking 50% of the tumor out safely, and then offering CyberKnife or stereotactic radiosurgery afterwards, then you've mitigated a lot of the risks. Fractionated may well be another option, but again, that's something I would discuss with your local team. So what do we know about tumor reduction via freezing, sound wave, or proton therapy? I don't know much about freezing or sound wave. I assume when we talk about sound wave, you mean ultrasound. Proton is another type of radiation therapy that certain units offer. I know Stanford offers it fairly soon. We'll be offering that here as well. But I would suggest discussing that with a radiation oncologist. What is the difference between Gamma Knife versus CyberKnife? Excellent question. So Gamma Knife uses a different source of radiation, uses cobalt, versus CyberKnife, which uses X-ray. And the difference with CyberKnife is that your head is fixed in a frame. I've trained with CyberKnife previously, and your head is held in a frame with screws going in, and the radiation is delivered. CyberKnife delivers it in an open platform, as I showed in that picture earlier, where the machine moves around you and delivers the radiation. We say that CyberKnife, the team that produces it, say that their accuracy is better than it is with the Gamma Knife. The other difference is a technical difference. So when you're delivering the radiation via Gamma Knife, it depends on how old the cobalt is. So the cobalt needs to be changed every few years. And if you are receiving treatment in the end of that cobalt's lifespan, the treatment takes longer because the cobalt is not as efficacious. Whereas with the CyberKnife, because it's X-ray derived, X-ray generated, it is always the same. Someone has asked a specific question about growth. I'm afraid without a time frame, I couldn't give you that, but we would say, it's very individual over what time period, how much it's grown, etc. And it takes years. So SRS causes some swelling, and it takes a few years to slough off the cells. The tumor is still there, so if there is pressure symptoms, that will not dissipate. Correct. That is correct. So when I talked about in the decision-making pathway we go through, I think if you are experiencing symptoms from pressure of the tumor, I'm not talking about edema, I'm talking direct pressure because of the size of the tumor, surgery is probably a better option for you because the pressure is removed. The aim of CyberKnife, Gamma Knife, whatever SRS you take, is to stop tumor growth. Yes, we do see some reduction in tumor size, but that is not a, we don't know how much it's going to reduce by. There is the chance that tumors develop edema afterwards, and that can make symptoms worse. So in those instances, a two-stage approach is generally accepted. Grade 1 meningioma, sphenoid ring resected, had a seizure during the night. I just had one and still taking Keppra. Is that common? I've not had any seizures since. And emotional issues. Okay, so if you've had a seizure as a result of the tumor and the tumor's been removed and you've been seizure free for a long period of time, I would go and speak to a neurologist, a seizure expert about this. It is not unusual for people to stay on anti-epileptics for a while, but if you've had good seizure control and you are noticing side effects from Keppra or levetiracetam, then having a discussion with a neurologist and saying, I want to do a trial without it, given that the underlying offense, the tumor has been removed, it is not unreasonable to say, yes, we can give this a go, particularly if you've got a long period of seizure-free interval. I would go and speak to a neurologist and have a discussion about potentially stopping that. They're the experts in that area. Is anxiety and meningioma related? Yes, for a variety of reasons. I mean, first and foremost, someone telling that you've got a tumor in your brain is bound to induce anxiety. But there are certain regions of the brain which can cause personality issues. So, if you've got frontal lobe tumors, they have been associated with personality change, with urinary incontinence, particularly if they're very large. But anxiety is a normal part of this diagnosis. And I do think if you are struggling with that, you go back and you see your neurosurgeon and your PCP and talk to them about your specific concerns, what you're worried about, whether it is a pathological effect of the tumor, depending on its location, or whether or not it is, health anxiety, which can be dealt with. Do you find this type of tumor more prevalent in African American women? We've seen a variety of stories and are curious if this is fact or fiction. I'm afraid I don't have that data to hand, but I think that's something we could pass off to next speaker, Dr. Gibbs, see if she will be able to feed that back to everyone. Should I have a consult with both a radiologist and a neurosurgeon to decide a surgery intervention? A 5 by 5 by 4 by 7 tumor. So it's not just to clarify, it's not a radiologist, it's a radiation oncologist. And I would say to you, you should go and see whatever you're considering, whether it's radiosurgery in the form of CyberKnife, Gamma Knife, or surgery directly. The person you should see is a neurosurgeon first, and let them sort of help you make a decision about whether or not your tumor is even suitable for either option. I think the way I like to look at it and the way I frame it with the patients is when neurosurgeons, we do an operation in the operating theatre, it is us and an anesthesiologist who are in there together. When we do CyberKnife, it is the neurosurgeons and the radiation oncologists in combination who do it. And so picking who the second person in that partnership is, it very much comes down to your neurosurgical team. So I think that's, I'd go see a neurosurgeon first, have a discussion with them about your operation, your options regarding surgery or stereotactic radiosurgery, and take things from there. Can women have IVF or undergo egg freezing after the surgery? Yes, you can. I've known many patients to do it before, after. There is, as far as I'm aware, no associated risk to fertility with the CyberKnife therapy because it is so precise in the brain. Upon having radiation enacted, what percentage of patients have either minor or major reactions temporarily or permanently? So the main risks that we talk about to patients with stereotactic radiosurgery is one, the risk of failure. And there's not a number I can give you because it's all individual dependent on size of a tumor, location of tumor, multitude of factors. But we generally say the smaller the tumor is when we treat it, the lower your risk of recurrence. And the other risk or reaction is possible swelling of the tumor. Now, as the tumor dies, it will release some inflammatory response, and that can cause edema or swelling in the brain surrounding the tumor. And we can manage that with steroids where possible. We can give you a short course of steroids to bring that down. There have been instances where it's been so bad that we've had to do surgical intervention. The percentage for that is very, very small, but I wouldn't want to give you a figure because I don't have that data in front of me. Is it typical if you have had a piece of your skull replaced that it may require having a drain permanently installed? So I think you're talking about developing hydrocephalus. So that is buildup of fluid in the brain due to the cerebrospinal fluid in the brain due to a disruption in the normal pathways. It is a known risk of surgery, particularly dependent on the location of the tumor. Hydrocephalus or this buildup of fluid may occur, which does require a ventriculoperitoneal shunt or a drain from the head into the abdomen. But that's something that we would talk to you about depending on the location. I can't give any specific numbers for whoever's asked about particular hormonal replacement therapies or shots being associated. Um, I don't have the data for that. Any augmented immuno or gene therapies available for certain type of tumor? I need to put my hands up and say that would be a discussion for the oncologists. They're the people who manage those therapies, and I don't want to give you an answer that would be incorrect. And they're the experts, and they're the people who know what the most up-to-date information is in terms of available treatment or any potential clinical trials that may be ongoing. Good. Brilliant. Any further questions? If not, I think I've kept you all for an hour this evening and we'll call it a day. No. Well, thank you very much, everyone, for your time. Oh, pleasure. Thank you. This is the main auditorium at Stanford. Thank you very much, everyone, for your time this evening. And as I say, if you want to see Dr. Chang, we're always happy to see patients. We do clinic 3 days a week, so we're always happy to have a consult with anyone who needs any advice, who's got any queries. All right, we'll end the meeting there. Thank you, everyone.
Thank you, Dr. Kalra.